My name is Howard Meng. I'm a first-year anesthesia resident at the University of Toronto. As a fourth-year medical student, I had the chance to work with Dr. Gordon on doing a research project looking at the challenges of EDS. I was interested in EDS because of the chronic pain, as many of you guys know. But as I've come to appreciate, there's also quite the diagnostic dilemma. So hopefully today I will be able to share with you some of these challenges. If we can move on to the next slide. This diagnostic dilemma of EDS is really challenging, and because the way that patients present in terms of the heterogeneity is challenging. So in terms of objectives for today, I really want to share with you guys the diagnostic tools available for EDS and really appreciate the different clinical signs and symptoms that present with these patients, especially with the hypermobile type, and also identify the needs and streamline appropriate workup as well as care for these patients. So Ehlers-Danlos syndrome, it's been described way back in time, but the guys it's been named after, Ehlers-Danlos, two physicians in the early 1900s, they described it as a distinct entity, something with skin extensibility and fragility. And of course, today we know it as, I guess it's branched out into something far more complex. So the Villefranche nosology, this is redone in 1997, and I think we've talked about it a little earlier, there are now multiple forms of Ehlers-Danlos syndrome. There's the classic, the hypermobility, the vascular, as well as a few other more rare forms. But as you can see, the more popular ones are the classic and the hypermobility. The hypermobility exists in a prevalence of 1 in 10,000 to 1 in 15,000. So what's important about these different classifications is that we've been able to separate them into their inheritance pattern, whether it's autosomal dominant or autosomal recessive. And for many of these forms, we've been able to identify genes associated with the disease. So for example, for the classic form, we've found COL5A1 and COL5A2 to be linked with the disease. And on genetic testing, which we would preferably do it for confirmatory I guess we would want to do it for confirmatory reasons. In the literature, it's been said that the COL5A1 and 2 has been involved in as low as 50%, but as high as 90%. And in terms of the hypermobility kind, unfortunately, the genes are mostly unknown. There's something in literature that talked about a gene called tenascin X, and there was a lot of excitement about that, linking it to the hypermobility kind, but unfortunately, the prevalence rate of that is only about 5 to 10%. So in terms of getting the bang for a buck with genetic testing for the hypermobility kind, it's not quite there yet. So there needs to be a lot more research into that area to look for ways to confirm our diagnosis. So what's important about the hypermobility kind? Why does it deserve more attention than all the other kinds? Well, I guess the most important of which is that it's the largest group within EDS patients. The patients that we see at the Wasser Pain Clinic, just statistically speaking, are most likely to be most hypermobile. And as I alluded to before, it's in the range of 1 to 10,000 to 1 to 15,000. The hypermobile kind also manifests as a debilitating disease. So we're talking about decreased mobility, decreased quality of life, although it doesn't cause the highest rate of mortality, but it's still, again, a debilitating disease, something that we want to look after. And we also want to be able to make the diagnosis of hypermobility or EDS hypermobility to differentiate from other joint diseases, other rheumatic diseases, so we can treat the symptoms slightly differently. So what do we have in terms of diagnosis of EDH or EDS-HT? Well, based on the Villefranche nosology, there's major criteria and minor criteria. The major criteria being hyperextensible skin, hypermobile joints, and the minor criteria being recurrent joint dislocations, chronic joint pain, as well as a positive family history. So patients that I've seen come through the clinic, they often say, I can twist my arms in all sorts of different funny forms. I've been labeled as double jointed. They're able to stretch their skin out from their abdomen, from their forearms. And when you ask about people in their family, they'll often be able to identify someone within the family as having had similar symptoms and having chronic pain. What's interesting here is that these criteria are fairly loosely grouped. And despite having major criteria for this as joint hypermobility, you'll see joint hypermobility being a major criteria in the vascular subtype as well as the classical subtype. So it's not very specific. And also in terms of diagnosing EDS compared to some of the other hereditary connective tissue diseases like Marfan syndrome, you'll get a typical Marfanoid body habitus, which doesn't quite exist in EDS. So it's a little bit more obscure. So how do we look at hypermobility? Dr. Francomano already talked a little bit about this. So we look at the dorsiflexion of the fifth digit, being able to bring your thumb down to your forearm, hyperextensibility of the elbows as well as the knees, and being able to touch the floor with your palms by bending forward. And if you get a score of greater or equal to 5 out of 9, you're labeled as hypermobile. Now, there's a few issues associated with the Baton score, and I'll talk about that a little later on. In terms of Brighton criteria, this is again a different criteria for hypermobility. It breaks down into major and minor criteria. And you can notice here that there's Baton score attached to the major and the minor. So a higher Baton score results in a major criteria, and lower Baton score is part of the minor criteria. It also includes joint pain, length of joint pain, and a few other features that helps to make the diagnosis of hypermobility. And a diagnosis constitutes as 2 major criteria, 1 major and 2 minor, or 4 minor. So along with hypermobility, there's also a whole host of other issues that patients present with. So we'll see cutaneous manifestations, musculoskeletal, neurologic, psychosocial, cardiovascular problems, gastrointestinal problems, and you'll also see genitourinary and gynecological problems. So what this really shows is that Ehlers-Danlos comes as a multi-system disease. It comes with numerous manifestations. That makes it very challenging for physicians to diagnose. What is the biggest thing that patients present with may not be the thing that leads you to a diagnosis. So at the Wasser Clinic, we really wanted to figure out how do these patients really present. We wanted to describe the different symptomatology of these patients that we suspect have hypermobility EDS. We looked at 48 patients, and Dr. Gordon diagnosed these patients based on history, clinical signs and symptoms, as well as the available imaging that we had. I myself went through the charts. We identified positive, pertinent symptoms, as well as diagnoses, what was negative, and being a chart review, we didn't have complete information, so some things were left undocumented. So the first thing that we really noticed out of our results was there a gender bias? Out of the 48 patients that we looked at, 45 were female. And this is consistent with what we've seen in literature. Dewandele's group, on a study of dysautonomia and EDS, all 39 patients were female. And so based on our group, it's almost a 10-to-1 ratio favoring females. And other reports have come out that have said females report pain more frequently than males. So not only is it biased towards females, but there's also a greater burden of disease associated with females. In terms of joint hypermobility, now Baton score for some reason was used fairly sparingly in our way of keeping track of patients. It was done in 17 patients. I mean, there are a few issues with the Baton score. There are differences as you age, so your Baton score might likely decrease. There are differences in gender, there are differences in ethnic groups, there are differences after you have surgery on the joint. So lots of things to think about, as well as the fact that the Baton score only takes into account a few joints within the body, not all the major joints. And for some reason, none of our patients were assessed using the Brighton criteria, and I suspect it's because it's more cumbersome to use and it's not as well entrenched in literature. The other issue is tissue laxity. So a fair portion of our patients actually were involved in sports, and we looked into that fact because we wanted to see whether patients being more flexible, more hyperextensible, or inherently predisposed to doing better in some sports such as figure skating, ballet, and gymnastics. We also looked at dislocations. 14 of our patients had documentation dislocations, and interestingly, 32 were left undocumented. So I think that perhaps goes on to show that, one, the dislocations themselves might be minor. They might be coming dislocated, then self-relocating, or the fact that it's patients aren't noticing them. The literature has also identified anal prolapse, pelvic floor dysfunction as part of the tissue laxity presentation. And again, we had only one patient identified as having pelvic floor dysfunction. So I feel like with the tissue laxity issues, we're not either not asking the questions or the patients aren't reporting them. So I think we need to look at doing a more comprehensive assessment when it comes to this. The pain manifestations, I think, is arguably one of the biggest problems patients face. And when we looked at the different areas of pain for patients, the face, the temporomandibular joint, the neck, the back, the upper and the lower extremities were identified to be areas of pain in more than 40% of our patients. The interesting part is that fibromyalgia, which is also a chronic pain diagnosis, these patients have pain over their entire bodies, multiple trigger points. It's a complex type of pain, and it presents as a prolonged chronic pain, as well as comes with psychosocial manifestations. To me, there seems to be a lot of overlap between EDS pain as well as fibromyalgia. And I wonder if there's perhaps a misdiagnosis of EDS as fibromyalgia instead. And looking at the pain regimen of these patients, you can see that there's non-steroidal anti-inflammatories, there's antidepressants, anticonvulsants, cannabinoids, injections. These are fairly common among our patient population. Also to notice is that 38 of our patients also used opioids. So I think this just goes on to show that the pain experienced by these patients is quite complex and very difficult to treat. The fact that they're on multimodal analgesics really makes this a challenging case. There are cardiac findings associated with these patients. So 17 patients complained of chest pain, complained of palpitations, and 18 of them eventually ended up receiving cardiac investigations. And that ranged from being totally benign, we found nothing, to patients having mitral valve prolapse, something that's been identified in literature. Along with that there's also orthostatic changes associated with EDS, and we suspect it's mainly from the dysautonomia, so the dysfunction of the autonomic system. Something called postural orthostatic tachycardia syndrome, whereby the heart rate increases or the heart rate stays at a sustained level over 10 minutes after tilt table testing without concomitant hypotension, is something associated with EDS. And out of our group, we had 4 patients diagnosed with that, whereas 15 patients also complained of some dizziness and unsteadiness, symptoms that we would think are associated with orthostatic intolerance. And I think part of the reason also lies within the fact that we need tilt table testing to make this diagnosis, that it's not quite accessible. In terms of GI complaints, we had a lot of our patients, so we're looking at 3/4 of our patients having some sort of a GI complaint, and irritable bowel syndrome being the most common. We also had gastric esophageal reflux and early satiety being common complaints. In terms of bladder symptoms, urinary incontinence was our most common diagnosis. And as I said before, given the fact that 45 out of our 48 patients were female, vulvovaginal symptoms were also very common. Dyspareunia and dysmenorrhea were the most common diagnoses. In terms of cutaneous manifestations, interestingly, Ehlers-Danlos, the hypermobility type, is characterized by the absence of the typical signs that we usually see in the Ehlers-Danlos patients. But however, if they do show up with the patient, they're recognized as clinically important in making the diagnosis. So the majority of our patients didn't have any cutaneous manifestations, and of the 18 that did, it was the easy bruising, skin laxity that we often see in other EDS patients that they came with. In terms of psychosocial manifestations, a large group of our patients had sleep disturbances, and not unexpectedly, they also had chronic fatigue. Interestingly, one group had attributed the chronic fatigue to muscle weakness and joint laxity as a reason, and so that's a very interesting perspective. These patients also had a lot of psychiatric symptoms, anxiety, depression, so the medications they were on, the antidepressants, the convulsants were perhaps not only for pain, but also to treat their anxiety as well. And last but not least, the majority of our patients experience some form of persistent headache, and it's often been described as migrainous in nature. So again, these psychosocial manifestations, although they don't sound very specific to making the diagnosis of EDS, I think these are very strong indicators of burden of disease that patients face. In terms of the limitations of our study, of course, this is a retrospective study, so some of the data were incomplete. And given the fact that we don't have a strict criteria to making diagnosis of EDS hypermobility, these patients were, of course, suspected to have the disease. So what can we do with the information that we've gathered is that at the Wasser Pain Management Center, it's a multidisciplinary group. We have specialists from all sorts of health fields: anesthesia, psychology, dentistry, obstetrics, neurology, psychiatry, sex therapy, nurse practitioners, as well as outpatient physiotherapy. So if the patient complains with chronic pain and injections are needed, anesthesia might do that. If they have some sort of other type of pain, neurology might see them. If there's a dyspareunia or some sort of sexual dysfunction, sex therapy can see. Or if they have mobility problems, outpatient physiotherapy. So the way we treat patients is very, I guess, based on their symptoms, and we have a variety of options. Another thing that we've also will start shortly at the Wasser Clinic is to do a patient intake form. As we learned from our study is that not everything is documented as well as we had hoped. So this multi-page questionnaire focuses on getting all the symptoms, signs, patient complaints into our database, and that way hopefully we can be more comprehensive about the way when we see patients. So ultimately, we would like to construct a database of these patients suspected or diagnosed with EDS, and it's to facilitate a comprehensive history as well as physical exam. And ultimately, we would like to be able to make the clinical diagnosis, but be able to pass on this information to our colleagues in genetics to be able to have a confirmatory genetic test. So, in conclusion, I'd just like to leave with you guys a few ideas here. That EDS hypermobility is very much so a heterogeneous, comes with heterogeneous presentations, and the challenge still remains in knowing what exactly is relevant. We know that the hypermobile joints, the lax skin, are kind of the hallmarks of the disease. But there are other manifestations that we need to keep in mind, whether it's gastrointestinal, genital urinary, or pelvic floor dysfunctions. Those also come as part of the presentation. And also, as I said before, psychosocial manifestations, although not specific to making the diagnosis, it's a burden of disease, and we need to keep in mind when treating the patient. And moving forward, we want to make a database of the patients for future research with the goal of ultimately having an early detection tool and be able to address patients' symptoms. So thank you very much for listening. I'm happy to take questions.
Any questions for Dr. Meng? Down here first. Can you use a microphone? Somebody pass her the microphone if that's an issue.
Dr. Gordon can also help me with questions.
No, you're on your own, kid. I've seen this before.
Is there any iron deficiency common on any other laboratory findings like serum vitamin D levels of 32 and C-reactive proteins of 33?
Dr. Gordon, would you have something to say about that one?
Never heard of it.
levels are very, very common, and they're very common in the general population these days. So this is another thing I think that we need to look at to see whether it's more common in the EDS population than in the general population. But regardless of that, treatment for low vitamin D is really important because low vitamin D levels can definitely contribute to the burden of pain. And then the C-reactive protein elevation is just a measure of chronic levels of inflammation, which is very, very common in these folks.
Great. Thank you, Dr. Frank-Cabana.
Yeah.
To add to that too, we've been doing Psychosocial analyses which look at trace element and vitamin deficiencies. Looking at 100 patients, we found that the vast majority of patients had deficiencies of vitamins and trace elements. The most common were the vitamin D, B12, pantothenate, B1, copper, oleic acid. Nothing significant in that.
Yeah, question.
Thank you I'm Gil, I'm a genetic counselor. Thank you for the characterization of your population and for the EDS in the clinic. I just want to point out that you've written out hypermobility is a hallmark of disease, and I really think we should be careful when we say that. And you actually said it in your talk. It depends on age, ethnic group, and it's progressive or regressive actually with age. So we have an information center for rare diseases in Quebec, and the population that calls us up the most is the ED or self-diagnosed EDS patients. And most of them are, the average age I would say is 40 years old, women 40 years old. And they have lost hypermobility, a lot of them. So Dr. Castori also indicated that it evolves into more rigidity. So I think we have to be careful. And also you talked about problems with the Baton score, and there are some that should be reviewed. At the International Symposium 2 years ago in Belgium, everybody agreed that the Baton score had to be reviewed. So I think, and so some who score average on the Baton score can still be EDS. And so I just think we should be careful with that. And
Absolutely, thank you for that. And I think just to add to that, the Baton score, as we talked about, is quite flawed. But at the same time, I think we really need to be able to standardize the way we score hypermobility. For example, one of our patients in the clinic was assessed by 3 different physicians. The Baton score actually increased over a period of 3 years from, I can't remember exact numbers, but it changed dramatically. So again, flaws, and we need to be able to fix that.
I think that the hypermobility is an important signpost, but I think the more important part, which you look at, is the widespread pain and the dysautonomia, which I think are really the things that actually cause us. I think that's where future research has to go.
I have PR type 1, and I was just wondering, out of the 48 people that you saw, did any of them have or had PR as well?
We didn't specifically look at Chiari malformations, mainly because it needed imaging, and we didn't quite have imaging on everyone, so it wasn't something that we looked at.
Okay, thank you. I was just curious.
Quick question, what is the average age of your patients?
35.
With the range of?
18 to 64.
Right.
Last question.
Hi, just to note on the vitamins, in my practice I've noticed there's a subset of patients which are deficient in vitamin D, but apparently they're very refractory to treatment, so require incredibly high doses to get them normal level. So some of them investigated for kidney dysfunction, liver dysfunction, and things like that. But there is a subset which are very refractory, as distinguished from the general population, which is generally some, you will find different deficient vitamin C and D here in Canada. Just
Thanks very much. Thank you, Dr.